Good evening. Thanks very much for inviting me to come and talk this evening. Nigel said that we were going to get two different viewpoints on chronic pain from different specialties, and indeed this is going to be the case. One of the issues with psychiatry is that the objective research data is pretty scarce for chronic pain. In fact, it's vanishingly invisible, really. There's very little by way of reliable research information, and a lot of the common practice is determined by clinical experience. So I shan't be giving you lots of papers to look at, and really just talk to you about my own perspectives from treating patients with chronic pain for really quite a long time now, probably about 25 years. I just wanted to start by talking a bit about diagnoses. And the first four, chronic pain disorder, chronic pain syndrome, pain disorder, are very frequently seen in medical legal reports without really much qualification. And I'm often confused by exactly what is meant by these terms. And I'm sure that many of you will be confused as well. And my advice is, when you encounter these terms, to actually ask the expert, can you please be a bit more explicit? Can you tell us what you mean by that? Can you define it? Chronic widespread pain and fibromyalgia are rather better defined with diagnostic criteria and so forth. As for psychiatric diagnoses, there are obviously two main classification systems, the ICD-10, which is the WHO system, and DSM-5, which came into existence in 2013, replacing DSM-4. Now, I'll talk a little bit about persistent somatoform pain disorder. This is the ICD-10 version. It's pretty ancient now. I think it was 91 when it was published. I'm going to draw your attention to a couple of aspects of this definition, which cannot be explained fully by a physiological process or a physical disorder. Now, that is widely interpreted to mean the existence or the presence of medically unexplained symptoms, which is something that's going out of fashion now in psychiatric circles for chronic pain. And the other aspect of the definition, which I want to draw your attention to, is which occurs in association with emotional conflict or psychosocial problems that are sufficient to allow the conclusion that they are the main causative influences. I mean, that kind of invites a lot of questions. I mean, who makes that judgment? Is it a psychiatrist? Is it a patient? Is it a GP? And on what basis is that judgment made? I don't think it's a very good definition, a good system of diagnosis to use. And I much prefer to use DSM-5. The DSM-5 definition focuses on the three important bits are numbered 1, 2, and 3, which are the emotional aspects, the cognitive aspects, and the behavioral aspects. And that's how psychiatrists will define and describe chronic pain patients. The diagnosis of somatic symptom disorder with predominant pain actually rather neatly sidesteps issues of causation altogether. You'll notice it doesn't say anything about what's caused it. What it does simply is to describe what it is and what the important features are, the cognitive, emotional, and behavioral. So issues of causation need to be discussed quite separately. I'm going to talk a bit about the clinical features of chronic pain disorders that reach psychiatrists. They may or may not coexist with a medical condition, so you don't need to say that it's not a diagnosis by exclusion. It's not medically unexplained symptoms equals some kind of psychiatric disorder. So, for example, the diagnosis of somatic symptom disorder with predominant pain can sit very neatly with a coexisting diagnosis of fibromyalgia. In my own experience, I often think that the two are often kind of very difficult to distinguish. There's a tremendous overlap between fibromyalgia and SSD. And I think that the difference is that with fibromyalgia, I don't tend to see patients with fibromyalgia who don't think excessively about it, worry excessively about it, or behave in a disabled way, which will define them as suffering from SSD. But I'm told they exist. So there's high levels of worry about illness. Bodily sensations are appraised as being threatening. What do I mean by that? Well, we all the time have a lot of bodily inputs into our sensory systems. If I suggest to you now that probably none of you are consciously aware of the pressure of your bottoms on the chair, the seats. But having mentioned it, you are probably now all aware of it. So there's all sorts of bodily symptoms, inputs, sensory inputs, which I like to think of it as kind of white noise. They're there all the time, but in normally functioning people, they're filtered out somehow. But in patients with chronic pain disorders, they're latched onto. These everyday kind of normal aches and pains are latched onto as being indicators of something really bad about to happen or happening. Avoidance behavior. Well, Roger's already touched on this, the avoidance of everyday activities through fear of causing pain. And Roger's also discussed fear avoidance. I think fear avoidance can be extended a little bit further than Roger was describing. I think it's not just the fear of being jostled or having your foot stepped on if you've got a foot problem. It extends beyond that to make people fearful of actually being out or being in public situations, just simply going out of a house or going into crowded places. I think that could also be considered fear avoidance. The pain symptoms, of course, will dominate interpersonal relationships, and it's pretty rare to encounter someone who's had a chronic pain disorder who will say everything's absolutely terrific in the relationship, there's no problems at all. Inevitably, nearly always, there are issues. High levels of medical consultation. By the time patients are referred to me, and I'm talking about non-litigant patients now, they've often been up and down Harley Street, possibly 2 or 3 times. They've seen all sorts of specialists, they've had all sorts of investigations, and they, of course, consult their GPs a great deal. There's an underlying belief about an undiscovered cause, and this is a question which is worth asking, because it's often quite revealing. Tell me, what do you really think is going on? Do you think something's been missed? It's worth kind of bringing it out to the open and discussing it, and then dealing with it in therapy. By definition, they aren't reassured for very long. Concurrent anxiety and depression is extremely common in patients with chronic pain disorders. And the relevance of that is that these symptoms of anxiety and depression will often need to be dealt with first. Roger's also touched on that. Deal with the frank psychological symptoms, see what's left after that. Having not appreciated that my slides were going to be disclosed, I was going to ask who recognises him, but now you know the answer. And I think that's a super quote from Proust, which leads me neatly into issues of iatrogenesis. Doctors are really not very good for patients very often. The common problems with iatrogenesis arise from side effects of drugs, and I'll include medically induced addiction under that heading, because it's very, very common indeed for patients of chronic pain to be addicted to analgesic drugs, the strong opiate drugs. There's one paper, I said I wasn't going to talk about papers, but there's one paper which I sometimes talk about, which estimates that 30% of patients actually suffer with definable, diagnosable dependent syndromes because of the analgesic medication. But most important, I think, is the unnecessary investigations and treatment. From my perspective as a psychiatrist, this is the main offender, I think, this under the iatrogenesis category, and I'm going to be very careful not to tread on any toes here about over-investigation and over-treatment. But what I can say is that most of the patients that I have seen have had countless scans, they've had countless referrals, they've had countless different specialties seeing them. I exaggerate a bit, obviously not countless, but they've been tremendously over-investigated. And so you might say, so what? Isn't that necessary? Well, actually, the answer is no, it's not necessary. And the answer is also that it's inherently bad to do that, because what it does, in psychological terms, is to reinforce very, very powerfully this notion that there's something terribly wrong. I keep on being investigated. I keep on having more and more scans. I keep on seeing more and more specialists. So it's a tremendous psychological reinforcer of illness behavior. So it's not just doctors that cause problems with patients of chronic pain. It's you'll be pleased to know, lawyers as well. Stress of litigation and disincentivization. I think that litigation can, in itself, sadly, produce over-investigation. And I'm not laying the blame at the feet of claimant lawyers, but very often it seems to me that there's some kind of drive to involve more and more and more experts and more investigations. And this it takes its toll. It's extremely stressful, and it also has the effect of reinforcing the notion of oneself as being very ill. Disincentivization to engage in treatment. I see litigants with chronic pain, and I also see non-litigants with chronic pain, and I treat the latter. I was saying to someone earlier today that the non-litigant patients that I see will very often get better. I'm certainly not claiming they all get better by any means, but they very often improve. I have yet to see, I think, a litigant patient improve significantly with pain management while the litigation's still going on. So I'm increasingly now an advocate of recommending that treatment should take place when litigation has ended. And I know that's not a very helpful thing to say for claimant lawyers in particular, but one has to have the patient's best interests at heart. And if you really feel that treatment isn't going to work, the psychological treatment isn't going to work, I've heard what Raj has said about getting on with treatment as soon as possible. And I agree with that in general, but I agree with that, I think that applies mainly to non-litigant patients. So I pretty much nearly always now recommend that treatment should be delayed. Vulnerability factors. The main vulnerability factors are to do with family history, pre-accident history, and I bring in the childhood history of abuse here because it seems to be something that's often asked about. Family history is quite interesting. I always ask my patients to tell me about their parents' health and their siblings' health, and it's not just out of a polite sense of inquiry, how are they? Because very often you will find that patients with chronic pain will have siblings, and particularly mums, with chronic pain disorders as well. I don't know why it's mums, it just is often the case. So that invites the question that, so is it learnt behaviour, or is it genetically determined? And, as with most things, I guess it's a mixture. The pre-accident history is probably the most important of all from the psychiatric perspective and from the perspective of assessing whether or not this is some form of somatoform disorder. It's vital, I think, from a psychiatric reporting perspective, to go through the medical records with a very fine tooth comb. Sometimes it's very easy. It's kind of a question of really weighing the notes rather than reading them. But it's not always that easy.
It's quicker too.
It's quicker as well, yes. When you have 7 DRH files of medical records, chances are you've got a somatizing patient. But what is interesting is that you will come across very often lots of references to minor complaints which the patient may just see the GP once or twice about, and the GP might write down IBS ? And then nothing. You don't see it again for a few years, and it might crop up again, and you might see difficulty swallowing, once referral, ENT referral, NAD investigations. You get a sequence of hints and clues of someone who's prone to somatization. Now, as a liaison psychiatrist, those are kind of yellow flags. You look at these and you develop a view that this is someone who's probably prone to somatization. If you're put on the spot and said, well, Dr. Master, do you think that amounts to a somatization disorder before the accident? The answer is nearly always no. But one says, from the psychiatric point of view, though, it's a yellow flag. And I think this person was vulnerable to somatization. The childhood history of abuse, lawyers always ask about this. There's deep fascination with this aspect of history. It is not very specific. It does predispose to somatoform disorders, and it does predispose to chronic pain disorders, but it also predisposes to just about every other adult mental disorder. So it's absolutely non-specific, but it's obviously of interest to note that that's one of the many vulnerability factors, and Raj has touched on several others in his talk. I'm going to end by talking about treatment aspects, because I think this is probably the most interesting. Always be aware of the possibility that the patient's significantly depressed. Depression, as we heard earlier, can interact very, very significantly with the perception of pain symptoms, and they kind of exacerbate one another. That's common knowledge, I guess. It's worth treating. If the depressive symptoms are significant, they probably need treating before you can make any headway with the pain symptoms. And the treatment may or may not involve medication. Very often, one does recommend treatment of antidepressant medication using all the normal criteria for indicators for that type of treatment. But CBT for depression is also important. And this takes me to the need for the unity of treatment for patients with chronic pain disorders. Very often, and sadly, the treatment is piecemeal. You find a therapist doing the depression, and there's another pain management psychologist doing the pain, and someone else doing the injections, and it's chaos. And the communication issues are very, very important. I think whenever possible, patients should be treated under one umbrella. Alcohol is, again, something that is a very significant factor in chronic pain disorders. There's a high incidence of excessive alcohol consumption, which patients will explain that I use it to either to get to sleep so I can get a decent night's sleep away from the pain, or it's used as an anxiolytic. But if there's high levels of alcohol going on, that needs attending to really as a matter of first importance before cracking on with other forms of treatment. Psychological pain management, I'll come to that in my next and final slide. Care. We're always asked, does the patient need care? Now, from a psychiatric perspective, the answer is nearly always no. And the reason for that is that the treatment principles are underpinned by the principle of normalization. You're trying to get this person to do ordinary things for himself or herself again. And if you ladle on significant amounts of care, it's counter-therapeutic. Return to work, sorry, I'm sort of one ahead of myself, aren't I? Return to work, I think return to work should be massively encouraged, even if it's on a voluntary work basis. It's important to restore confidence. Just getting back to do something is confidence boosting. It gets people out whereas they may be stuck indoors a great deal of the time. Analgesic withdrawal, vitally important, and I think often ignored. It's an essential part of treatment. I'm sure Raj would probably agree with me that analgesic medication actually doesn't work for patients with chronic pain. It doesn't work. I mean, they still have the chronic pain symptoms, and they're on massive doses quite often, or combinations of various analgesic drugs, which have the effect of making them dependent, which in itself is a major factor preventing improvement, because consciously or subconsciously, they actually quite like the tramadol or the opiates. And of course, it causes sedation and general lack of motivation. So it's very important that no pain management program should take place without a concurrent withdrawal from analgesic regime. What I usually do is I say, look, you're on this amount of medication now. What we're aiming for in 3 or 4 months is for you to be on none. And it sounds fairly drastic, throw up their hands in horror, but how can I cope? And then you have the same discussion that you had before. Well, actually, does it help? You told me no earlier on. No, so on it goes. So analgesic withdrawal is very important. Principles of psychological treatment. I'll just quickly go through these. This is my final slide. Group treatment or individual. My preference, and I'm not saying, there's no evidence, incidentally, for the relative benefit of group versus individual treatment. There's no research evidence. So, you pay your money and you take your choice, really. And if you refer to residential 4-week programs, you pays your money a great deal of it. And I think residential pain management programs have their inherent disadvantages. They are not tailor-made. There's a certain cohesion that can go on in groups of people with chronic pain. A sort of camaraderie can develop, which can be, in my experience, somewhat counter-therapeutic. I prefer individual treatment, and I prefer it to be done as an outpatient. There's no real rationale for residential treatment. Therapist availability, this is a crucial issue. My recommendations are nearly always for a clinical psychologist who's expert in the management of people with chronic pain disorders. And then the big question is, where do we find this person? Because I'm sorry to say, they're relatively few and far between. It's just a fact that they're very difficult to find. There's a cluster in London, but it becomes more difficult as you go out of London. Therapeutic relationship, the reason I put that in there, when you see someone, as a psychiatrist with a long-term pain disorder, as I was saying earlier, they've been up and down Harley Street, they've seen lots of specialists, they've had lots of investigations, and then, horror, they're in front of a psychiatrist. And what they automatically think is, well, why am I here? They think I'm mad. If I'm not mad, they think I've made it up. So you have to spend a huge amount of time. Quite often, I find myself spending a whole session or even 2 just going over these issues about the nature of pain symptoms and how one accepts them at face value and reassure them that they're not mad, and so on and so on and so on. So the therapeutic relationship is a tremendously important aspect of treatment. You also take great care to say, look, the objective is not to make the pain go away. I'm afraid I can't make the pain go away. What we can do is to generally enhance your life. We can make you much more functional. We can reintroduce you to activities that you've given up for a long time. And the way you do it is to start off with a sort of battery of baseline measures, largely behavioral. give me a 24-hour diary of what you do. Let's have a look at it. Can you keep this diary for the next week or two until I see you again? And we'll do an analysis, a behavioural analysis of what your life looks like at the moment. A lot of it seems to be sitting down, staying in bed, not going out. I often will say to my students that it's quite often it's helpful to do a can't do and do too much of list, two lists. So you have a list of all the things that they can't do, because these, and they'll tell you, I can't shop, I can't garden, I can't hoover, I can't do this. And you try and develop some sort of hierarchy. And the things that they do too much of, illness behavior, the expressions of distress, the expressions of pain. It's very helpful to see patients with their spouses, if they have one. And a rather low trick sometimes that I do is to hand each of them a piece of paper. And I say, now, I'm going to ask you a question. I want you to write down the answer, each of you, on a piece of paper without conferring, and then we'll look at the answers. And the question is, I want you to tell me how much of the time between you is spent talking about pain. Okay. And, you can anticipate what the answer is. The patient will tell you 10 or 15%, and the spouse will tell you 80 or 90%. There's a massive discrepancy. And there are ways, to address these issues. I think that partners who are invaluable as co-therapists, have I got co-therapists there somewhere? There. They're invaluable to act as co-therapists. They should be involved in all aspects of a psychological management program, because they can do it every day, all day, and you may only see the patient once a fortnight. The co-therapist's got to be given permission to do things which are counterintuitive. Don't please always get up and make the tea. Encourage him or her to make the tea. Don't always do things for your husband, stroke wife, or son, daughter. Let them do it themselves. I seem to have done something here.
That's your time's up.
I think that was a sign, yes. Well, actually, I will stop there and perhaps invite any questions.